for nephritic syndrome, I just want you guys to know the examples by heart. Like, you should know that nephritic is basically PSGN, IgA nephropathy, rapidly progressive, diffuse proliferative, membranoproliferative, and then Alport syndrome. When you have like when you get a case, for example, when you get an MCQ and the proteinuria is in nephritic range, so already your DDs have been narrowed down to like 5 or 6 diseases, right? Further, with like some mnemonics, you can then make like the diagnosis. I think nephritic is probably like the easiest. So, for example, let's start with PSGN, right? So there's infection related glomerulonephritis. So with PSGN, one thing how I've basically learned is that it's PSG, right? So just convert this G to 3. So it's PS3. So for 3, remember type 3 hypersensitivity. And for some reason, this is like, this comes a lot of times on UWorld. I don't know about the MCQs in our medicine paper, but like, it's important, right? So type 3 hypersensitivity. Next we have the type 3 hypersensitivity is basically immune complex deposition, right? So type 3 hypersensitivity, next with 3 you need to learn is that there is this decreased levels of C3, right? Then you need to know is ASO. This is the definitive diagnosis. So these are 3 alphabets. So ASO titers, this is how you make like a definitive diagnosis of by the ASO titers, right? Next we have so this is 3 weeks. So this is 3 weeks post infection, right? Which infection? The group A strep. And the last 3 is okay, this is a bit weird, but lumpy, bumpy. Okay, and I don't know, I've always learned why with 3, so it's a common mnemonic. So that's how you learn PSGN's clinical features and like how to make a diagnosis. So it's pretty obvious. Type 3 hypersensitivity, when a child has like a group A strep, for example, the child has history of skin infections or pharyngitis, and now 3 weeks later he's presenting with hematuria, then you're gonna think of infection related glomerulonephritis. So this is like starry sky appearance on immunofluorescence. I do not think so this is that important, but you can just learn it from here, or if it's on step up, then you can learn it from there. How do you manage it? So normally you just if it's a child, so you just do supportive care, but for adults, it can rapidly progress into rapidly progressive glomerulonephritis. So you need to manage it more vigorously as compared to children. The prognosis is basically better in children. So next is IgA nephropathy. So IgA nephropathy, I don't know if you guys remember, but we did learn IgA vasculitis, which is Charlene purpura. So it's very much similar. So it basically occurs concurrently with respiratory or GI infection. So if there is a child that's presenting a few days after a GI infection, you don't have to be confused between PSGN or IgA nephropathy. It's definitely IgA nephropathy. But if the child is presenting after a respiratory infection, I mean, it's very easy to be confused. But if it's like after a few days, then it's IgA nephropathy. But if it's like after 2 to 4 weeks, then it's PSGM. So GI tract infections or respiratory. Okay, so you see it's mentioned over here as well, renal pathology of IgA vasculitis. So basically this is like IgA immune complex deposition in the mesangium. So that's like the main cause of this this type of nephritic syndrome. The patient will again present with hematuria and what we have already. So the clinical symptoms with which the patient will be presenting is same, but the causative like the etiology, you need to know that. So for that, we are done with PSGN and IgA nephropathy. Let's move on to rapidly progressive glomerulonephritis. So this basically consists of like 3 you basically have 3 types to this, right? So number 1, like I said, that PSGN can progress into rapidly progressive glomerulonephritis